within this, for-profit healthcare has been rising and rising, and it's shocking to think that, for example, hospice care would be a majority for-profit game. Dialysis in the United States is largely dominated by 2 for-profit companies. Nursing homes are, the largest owner of nursing homes are private equity firms. And so the seeking of profits really influences the U.S. healthcare system. One hopeful thought is that for the most part, general hospitals remain not-for-profit or public institutions. The same is true for psychiatric care. So it might be a good starting point if there were to be delivery reform. But I think that it's not just that there's profit seeking and all of the things that come with it, mergers and acquisitions and all kinds of deal making, all kinds of consultants, all kinds of people getting a piece of the action in the game. And it's not also the fact that there are obscene personal rewards. These are some of the insurance company executives, but we might point also to big hospital conglomerate executives, pharmaceutical executives. So it's not just the profits go out, it's that there's an enormous amount of administrative bureaucracy in order to capture these profits, and that competes directly with providing for the needs of the patients. Meanwhile, in the United States, the wealthy have gotten very, very wealthy, but the poor have actually gotten poorer, making it harder and harder for working families to afford health care, and health care costs have far outpaced incomes year after year. So these are the contradictions that set up the need for health care reform, that the United States spends so much more money than it ought to, really, on health care, that compared to other nations, that the costs, out-of-pocket costs, and the costs on working people are not affordable, and then that the results are not there. We've now seen this incursion of high deductible plans. These are percent of workers with deductibles of $1,000 or more, $999 or more, rising and rising and rising, pushing the costs of care onto individuals even as we don't get the results. And with the polarization of incomes in the United States, most households really are not able to pay high deductibles, so that you might have a high deductible insurance plan, but if a health calamity were to befall the family, it would prove bankrupting. This is a phenomenon of underinsurance. We see this is from the Commonwealth Fund over the decade. Those who are underinsured, who lack adequate family assets to face a healthcare calamity, has grown significantly. Meanwhile, if we look at those who are bankrupted by medical costs, most people at the outset of a bankrupting illness have some form of health insurance. In fact, this shows 78% of those bankrupted by healthcare costs have a form of health insurance. It's shocking to think that being insured does not protect us from bankruptcy. It seems like be the whole point of having insurance at all. Medical costs are directly in the way of getting care. This shows that those reporting any problem paying a bill or a debt, anybody who's gotten a collection agency call, people who have had to pay for their health care over time, has increased significantly from 2005 to 2010 to 2012. And similarly, those reporting that they didn't go to the doctor, didn't get a prescription, skipped a test, or skipped a specialist visit, or couldn't get one, has similarly increased. So the costs of care, not just in aggregate for the nation, but personally, especially when it comes to the middle class and working people, the costs have become a grave problem. And we know that people die simply because they don't have health insurance. And this PNHP data that there were about 45,000 deaths annually due to uninsurance. And in many ways, it's this fact that has, if you will, driven the bus of health reform. This shame of the nation has pushed things forward. But at the same time, our health delivery system has hideous disparities. David Satcher's famous study from Health Affairs in 2005, he was the Surgeon General under, he's very proud of it, both Clinton and Bush. David Satcher and his colleagues pointed out that over 83,000 African Americans would not have died in 2000 if the racial disparities gap in the United States had been eliminated. So it's this contradiction, all the money, and yet costs are unaffordable, all the aggregate money, and yet costs are unaffordable, all the whiz-bang ability of the system, and yet we don't get the results. That makes health reform a continuing imperative. And so the Affordable Care Act was enacted under President Obama with the hope of reducing the number of uninsured. Now, the yellow line on the right shows the intended impact of the ACA. With the Medicaid expansion, the uninsured would be reduced from 48 or 49 million down to 30 million. Now, the goal, of course, should be to reduce the number of uninsured down to 0 to prevent all of those deaths that people suffer simply because they don't have health insurance. But this was the best that the establishment felt it could do. Then, I think I misspoke. The red line is as it was intended to be enacted. And then with the Republican backlash state by state, the goal of reducing it under 30 million could not be achieved. The way that the Affordable Care Act works is that there's compulsory private health insurance for those who can afford it, and Medicaid's expansion for everyone just above the poverty level. With that expansion, this is a little bit of an enlightening way to think about the impact of the ACA directly on people. Without the ACA, there would be 56% currently in private insurance, 10% of the population would be covered by Medicaid, and 18% uninsured. With the ACA, uninsured would be reduced to 10% of the population. Private insurance in total would be expanded to 60% from 56, including those who get health insurance through the exchanges, plus a significant Medicaid expansion of up to 14% of the population. I think that we could bear in mind this slide when it comes to a discussion of the impact of the ACA, because the fact that a small proportion of the population will be directly impacted is something we might think about. And I think the ACA will, in fact, impact the entire health system, and then ultimately all of us. When it comes to Medicaid expansion, it is good news. Medicaid absolutely helps. This is the events in Oregon, sort of the natural experiment where a lottery for Medicaid spots meant that those who didn't get Medicaid were followed against those who did. And sure enough, if you were able to get Medicaid, you were more likely to get a mammogram, a pap smear. You were able to take your medications if you were diabetic to a significant degree that you couldn't have if you didn't get Medicaid. On the other hand, Medicaid remains in many ways indefensible. This is a position that I've been in personally in the past on many occasions with disabled patients who had Medicaid, trying to get them in to see an orthopedic surgeon, a dermatologist, or an otolaryngologist, for example. When Medicaid is the only insurer, access is not solved. So the Affordable Care Act was going to take on health insurance reform. It would make essential benefits, but not a standard benefit package. Copays and deductibles, which are things that we believe the evidence shows inhibit people's ability to get adequate care, would be eliminated, but then the Affordable Care Act only eliminated those for preventive services. Insurance overhead was limited, the medical loss ratio, but of course the ACA rollout will still be state-by-state regulation of insurance, which is where the insurance companies would like it, and also the medical loss ratio becomes something of a game where if the insurance company employs a nurse to call a patient, then that is counted as care, not as part of the overhead, for example. Premiums, deductibles, and copays are unregulated by the Affordable Care Act, and there are out-of-pocket caps on total spending, but uncovered services and in some cases drug costs are left out. So the health insurance reform under the ACA is some regulation upon the private health insurance industry, but far from sweeping reform that would change things profoundly. This is an example of the cheapest coverage options for a 50-year-old person here in my state. There would be $300 a month premium perhaps, with a deductible of $3,000 per person or $6,000 per family, with out-of-network coverage not offered. The other thing is that all kinds of cost sharing is introduced to make the premiums affordable. So a primary care visit requires a 50% cost share that's subject to the deductible. Perhaps that could help a little, but 50% co-insurance is quite steep, especially similarly for specialist visits, home health care services, inpatient hospital services, inpatient physician and surgical services. So the push of the tendency of the push to put costs on individuals has not really been ameliorated by the Affordable Care Act, and in some ways, with this being the example in the exchanges, perhaps accelerated. The exchange itself has, exchanges themselves add significant overhead, and this is the example of the Vermont exchange. Ida was telling me quite a bit about the efforts to implement some of the exchanges state by state, way beyond my depth. But the example here is that the initial cost of the Vermont exchange was $170 million up front, which would translate into perhaps $6,000 per person who gets insurance, who is anticipated to get insurance through the exchange, or $1,700 per user of the exchange. A very significant amount of money if you think about the average per capita health spending in Vermont. We could also think about whether the ACA will be able to impact costs simply by looking back at Massachusetts, since Massachusetts was the model for the Affordable Care Act, and in fact costs in Massachusetts rose faster under this mandate model health insurance reform than compared to the nation as a whole. The things that have been pointed to as cost savers are the implementation of health information technology, and I think there's some significant data to suggest that health information technology ends up costing more money. Chronic disease management, which may be a wonderful idea for patients who are suffering severe chronic diseases, but doesn't necessarily save costs, and payment reforms, bundled payments, and value-based purchasing and accountable care organizations, all of which have not been shown to save money and very likely will cost more. And then if we think once again about Massachusetts, we remember that Massachusetts reform was not paid for within Massachusetts. There was an enormous gift to Massachusetts of federal money to subsidize the reform. There will be no similar angel for the United States as a whole. In Massachusetts, also, premiums have risen and benefit levels have fallen, accelerating the tendency of pushing the cost directly onto individuals who are in the middle and working classes. There are ironies in this Byzantine system that results, for example, if you have breast cancer and are trying to buy a plan in Massachusetts, a bronze plan on the exchange in Massachusetts, you might want to pick Plan C, the Plan G, because your anticipated out-of-pocket cost will be $5,000 less than if you picked Plan C. But if you had diabetes, it would be smart to pick Plan C instead of Plan G. You can see at the bottom where the anticipated diabetic management costs for an insured patient for Plan C would be $960, but Plan G would be over $4,000. And the devil in these kinds of details is, in my opinion, well beyond the wherewithal of many of my patients. Underinsurance thus becomes the norm. Right now, the average employer plan provides 87% of actuarial costs, and that's the protection that, although imperfect, is what we've got through our employers. And the new standards of bronze, silver, and gold covering 60%, 70%, and 80% of actuarial costs at the best may touch off, for labor unions especially, something of a race to the bottom. The idea that the exchange plans are the new standard and that employers will scarcely see a reason to do better than what can be obtained on the exchange. we thought we should include a few slides about ACOs, and because of the growth and encouragement of accountable care organizations. And they make sense because of some of the failings of our system. We have a lot of high-tech facilities, but many things are redundant in our system. Patients get testing that's completely unnecessary. There's a lack of communication on many levels that should be built into the electronic health records. Primary care, public health, prevention, and mental health are far from what they could be in our country. We have silos rather than teamwork and coordination. We have serious quality problems that need systemic, not individual solutions, and public accountability continues to be out of reach here in a democracy. So for all those reasons, it would make sense that some kind of accountable care should be delivered. The logic, however, is that fee-for-service is the entire problem, and we need to go to capitation. And this comes through the policy literature loud and clear these days. The consequence is that small clinics and hospitals can't bear the risk, and so to protect themselves, they're finding another incentive for consolidation and conglomeration. And then this risk shifting creates all kinds of incentives to deny care, to cherry-pick patients, and of course also to buff the charts under our current system. Getting into the fray on top of everything else are the insurers simply looking for profits, and these are examples of where ACOs can lead. United Health buying Pioneer Medicare ACO and directly employing 2,300 physicians. WellPoint conquering 28 clinics and hiring the doctors, and Humana buying up practices with 1,500 providers. So the insurance companies then become the owners and drivers of it all. Right next door in Canada, we have a nearly apples-to-apples comparison of how things could be. The Canadian system has universal coverage. Everyone has access to all necessary care. There's portability of benefits from province to province, and the benefits are not tied to a person's job or their spouse. Coverage is, I've already said it, coverage is widely available, and it's a publicly administered nonprofit program. In Canada, if you look at the question of unmet health needs, and the Canadian system is not perfect, the unmet health needs in Canada are about on par with the unmet health needs for those in the United States with health insurance. Canada has absolutely proven that single payer can bend the cost curve. When Canada's Medicare was enacted, its costs were tracking with the United States, and you can see the difference since. I always thought this was a little tricky to think about and explain. The pie here is the entire pie is the difference between health spending in the U.S. and Canada. So, you know, the whole pie is about $5,000 difference. The United States spends about $5,000 per person more than Canada spends per person on health care. But of that pie, pretty much pushing on toward a half is simply bureaucracy and administrative waste that the United States would not have if it adopted a system like Canada's Medicare for the nation. National health insurance is popular, and it's been popular year after year. This shows that the proportion of people who would like to see the government provide the coverage grew from over 1979 to 2009 from 50 to 59%, and those who wanted to rely on private enterprise shrank down to just a third. Many of those who oppose the president's reform prefer single payer, and so the idea that everyone against the president is also against the single payer idea is not true. And if you look at this in total, we really have a significant majority who believe in single payer. National health insurance in the United States would cover everyone. There would be no death from the lack of health of uninsurance. It would be comprehensive and cover all necessary care, which would give us a way to at last tackle delivery reform. There would be one public payer with simplified reimbursement. We would have no investor-owned delivery of health care, no one taking a piece of profit out or employing an army of clerks in order to figure out how to do it. The money and the resources would go to care. we would begin to tackle the question of health planning and prevention, primary care and mental health. We would also have public accountability with the least amount of bureaucracy. We have plenty of revenue, and if we took the existing sources of revenue from Medicare and Medicaid and state and local spending, employers, the private insurance revenues, we could easily afford the National Health Insurance Fund. The Tobin tax is in the H.R. 676 Conyers legislation. It would be a progressive way for the wealthiest to subsidize the care of everyone. We actually have what it takes. This is where I started, and we can do this. It's just a question of the political will. Thank you. So that was 25 minutes.
That was nice. This is Michael.
Hi.
Is this set on the website if we wanted to use it?
We will send it to you guys.
Okay. I have a talk scheduled next week to 20 healthcare workers.
Terrific.
So you're going to send the set of slides you just discussed to all of us?
Yes.
Okay.
Andy, are you soliciting questions?
Yeah, this is it. I should have said, I'd like to open the floor, and if you want me to talk, just talk more. I can talk more about my thoughts about this set, but go ahead.
Well, the first is a comment. I mean, one of the things that's so admirable is how fluent you are. You know the slide set so well. You're anticipating the shift from one slide to the next. You've got the patter down pat, as it were. And I'm assuming that you would recommend that each of us practice our patter before performing.
I suppose. I mean, maybe not. I mean, I do think about this in this way. Like, the first thing about, well, what's going to drive this is that we have the resources, but our system fails. So in many ways, it's just making that point again and again, pointing to the evidence that says that we could do this, but instead we're doing that. Or so I think that those ironies are what I learned as my spiel, if you will. And I think that's sort of been one of my contributions, is to popularize the presentation of the evidence.
Well, thank you. So I have two specific questions, trying to anticipate what some of the audience might say. The first, with regard to the Oregon Medicaid experiment. I know there's been some recent new data that has been popularized as saying that Medicaid is not saving, that the outcomes are not as good as we thought with the first set of data. Could you clarify that for us?
So you might get someone who says, I read in the Wall Street Journal that those with Medicaid actually were more likely to go to the emergency room than those without. And so therefore maybe we shouldn't give them Medicaid. Ida?
Well, if you think about it, they're sicker and poorer, so they are going to utilize the emergency room as well as other caregivers more initially. Hopefully with the Medicaid coverage, especially in Oregon where they're setting up this coordinated Medicaid, they will get hooked up with providers and so forth. But having insurance coverage doesn't mean that a sick person doesn't ever need to go to the emergency room.
There's also a severe shortage of primary care doctors in Oregon, especially east of the Cascades. There's almost none, so you have a lot of people who now have insurance but no access to outpatient care, so they have nowhere to go but the emergency room.
That's correct.
Therefore, it's arguably a very good thing.
Oh, well, previous studies of emergency room crowding and so forth have found that most people are there with most of the people that are there with insurance, but they can't get a same-day appointment with a provider to deal with an urgent health issue. So that's probably exactly what's happening. You know, what you just said is these patients, they now have Medicaid, but they cannot get a same-day appointment to deal with whatever health problem they have, or, you know, flare-up of whatever chronic disease or so forth.
Is that helpful? If you really wanted to dig into the question of the Medicare experiment, Erin Carol's blog, The Incidental Economist, had pretty thorough give and take about how to look at the data from Oregon. It was incredibly good.
What's the title of that? Incidental Economist?
Yeah, it's Erin Carol's blog, and I wouldn't think it would be too hard to find his take and some of the other bloggers there about the reception of the data from Oregon.
Andy, this is Don again.
Hi. Don?
Okay.
I can't see everybody, so.
Another question. Do you have any advice about the best kind of state-specific data for us to gather and try to incorporate into this slide set?
Well, I'd be very interested to hear what Ida thinks about that. In the beginning, a few years ago, I was.
Well, I'm sorry. What was the question?
Oh, the question is advice about state-specific data. And in the beginning, when I would try to do this talk, I would try to localize it. Say, well, in New York State, the impact would be whatever on our costs, or because many of us have found that if you can explain what the elimination of health insurance would mean for the local school district, or the elimination of Medicaid would mean to the state budget, that those are compelling arguments. I think now, in terms of some of the things that have happened state by state, it can get very interesting because of the implementation of the ACA being what people want to talk about. You know, and some of the very poor states, Medicaid expansion really has a lot to offer. So I don't know. You'd have to know your audience pretty well to decide which tidbit to throw in. Ida, what do you think?
Well, I think the number of uninsured, and I think there is state-by-state data on medical bankruptcy, estimated numbers of people that are bankrupted by medical bills. There's also state-by-state data on health statistics, you know, like infant mortality and so forth, that Kaiser Family Foundation website has a whole, you know, state health data section. So if you're, you know, that might make your slide set seem a little more customized to your audience if you know, had the infant mortality for your state versus other countries instead of the national one, for example. But I don't think you need to do too much. I think that the national situation does apply to most of the states, so I think just a couple are really all you need.
Well, and also the mortality, deaths due to uninsurance is also available state by state at the PNHP website.
Andy and Dick Denver.
I have a question.
How about?
Should I talk?
Go ahead.
Okay. I'm just across the state line from you, Andy, in Bennington, Vermont. And we invite you over here, by the way, to give this grand round so I don't have to do it. Anyway, it seems to me as if our problem here in rural Vermont is that we can sign people up for health insurance now, but we have no primary care access. There's not a single physician in town who is taking new patients. And do you see any way that we could tie the PNHP goals to the primary care crisis that we face, so that primary care physicians would, as a group, buy into this and increase our visibility and increase our ability to care for patients.
Well, that's a terrific point. This slide, hospital mergers rising, one of the slides I deleted from the short set that comes next is that shows that most physicians, I wonder if I can find that, most physicians are employees of hospitals and new physician. Where is that? There we go. That slide. Can you see that?
Yes.
So this is something to think about. I mean, a majority of general surgeons work for hospitals now. All kinds of specialists work for hospitals now, and there's the whole hospitalist movement, which now has something like 40,000 hospital medicine physicians. The idea that we're becoming employees is something that I think is a subtext in the slideshow. Pay for performance is a very long section in the short set also. See if I can get to that. And I think that that discussion does resonate with our colleagues and something we should take to them. Where's pay for performance? In the long set, maybe. So those questions, I think, are absolutely the theme that we should be trying to get to, and we should be saying to our colleagues that, if you really want to fight for the power of the profession to say what the standards of care should be and to be able to advocate for our patients one by one with the maximum amount of effectiveness and liberty to do the best we can for them, we're going to have a publicly accountable system, because what we have right now is not it's undermining our profession. It's and the idea that we will become simply financially incentivized to do what's right for the system is to completely undermine our place as a profession. That we are caregivers, that we're part of a caregiving team. All of those themes, I think, are the ways to build PNHP, and so something to think about. The single payer as rescue of the medical profession. It's a whole theme that I completely believe we should develop. Is that useful? Easy enough to add 3 or 4 slides and still keep this within keep this time within easily within the Grand Rounds slot. I would just add that one of the things that we often do that's a mistake is we get so excited. I did this myself in Ithaca. So excited to share the data that you kind of leave the audience exhausted, and yourself too. And then there isn't time for questions, and you've forfeited an opportunity to recruit to the group. And so it's very, very important to stay within the 35, 40 minute, at the maximum amount of time. So many of the data are so provocative anyway. You only really have to show a few things before people really want to erupt. So the wonderful thing about single payer is that it's so well grounded in evidence that if you make the initiative, you will get a response and a positive response. It's quite exciting. So that's a little bit rambling, but I think your criticism is right. This slideshow would be improved with 4 or 5 slides about what's happening to our profession. Very uncomfortable to talk to the computer. There was a woman that was trying to speak a couple of times.
Yes, hi, this is Inga Debeck from Minnesota. I wonder if
Oh, no.
Looks like we lost Andrea Becker.
All right. Someone else?
This is Steve Kemble in Hawaii.
Hi,
And
Steve.
the issue of the way that physicians becoming employees of for-profit organizations undermines professionalism is one of my favorite topics. I've been trying to figure out how to condense that enough to squeeze it into a talk without it becoming too long. I think it depends on the audience. For physicians, I think it really resonates. For other audience, it may be something to be included in the discussion, but not necessarily a core part of the presentation. One specific question I have a talk coming up for the Rotary Club here, is what is the financing proposal in terms of the breakdown between individual income tax and business payroll taxes under HR 676? Because I think that's a question that may come up.
I can answer that. Dr. Gerald Friedman did a study, a fiscal study of HR 676, and estimated that it would save $500 billion in overhead and spending on overpriced medications. And that with that savings, then the payroll tax rates you would need to replace what's currently spent on premiums and out-of-pocket costs would be would depend on whether you have a Tobin tax. If you have a Tobin tax, which is a tax on stock transactions, very small one, it's like a penny a trade, I think, or something like that. If you have a Tobin tax, then it's a like a 3% payroll tax and a 3% surcharge on the taxes of the wealthiest 5% of Americans, and a 3% tax on unearned income. If you have, if you don't have the Tobin tax, then I think the tax rates were like closer to 6%, where you would need a 6% surtax on the top 5% of incomes, and a 6% payroll tax, and a 6% tax on unearned income, which so it depends a little bit on whether or not there's the Tobin tax. So I tend to think that the Tobin tax is a really great idea, but it's a long shot. So so I tend to use the figures for not using the Tobin tax.
Okay,
we have a slide on that.
We have a report on it. I don't know if we have a slide on it yet, but I can send it to the group.
That would be great.
Yeah, that'd be terrific. Thanks.
One other aspect of this is this came up in some of the one-pair state discussions, is that the payroll tax could be either a tax on the gross payroll, or it could be a tax per employee, per full-time equivalent, let's say. And if it's per full-time equivalent, it's more like a premium than a graduated tax based on the compensation of the employee. And it would then not have a disincentive to pay people more. Whereas if you make it a percentage of income instead of based on the number of full-time equivalents, there's a disincentive to raise people's pay because it raises the payroll tax.
I think the historical reason that there was a idea of a small income tax and a progressive one combined with a payroll tax was that the popular supporter of single payer, the Labor Party, with Tony Mazzocchi, the labor leader, the principle was that the employers should continue to pay for health care and that workers should not have to pay more than 5% of their income toward health care. And so within those bounds, proposals for funding popped up, and many of the proposals for funding single payer then have been on some kind of a payroll tax idea. And once upon a time, Marvin Malik from Vermont made a point that I thought was great, which is that any tax can be explained as unfair, so that companies that have lots of payroll expenses but low capital expenses suffer differently than companies that have low payroll expenses but lots of capital expenses. And you can't make it fair for all the businesses. You can't make it fair for all the others. And of course, the question of a general progressive tax on the wealthy then comes up, and that's why the Tobin tax, I think, is nice to explain, the idea of a transaction tax, just a few % of each financial transaction, because it kind of leaves working people completely out of it, since we don't, have big transactions.
Hi, Andy. This is Inga Debeck again. I kind of
Hi,
dropped into I dropped into the polar vortex or something. I don't know if you were able to hear my question.
No, I'm sorry.
Before? Okay. So my question is this: I wonder whether adding a script to your slideshow, the one you just presented now, and the script would be, I'd like to have it right as you said, because it flowed so nicely, it was so well paced, and something that we have found helps here, for people who start to go out and talk, have not just the slides, the script that goes with it. And then people find, and of course they don't need the script anymore, but it's a real help.
I'd be glad to try to work on that.
That would be great. Thank you.
Someone could just transcribe the session being recorded, perhaps.
Yeah, I think that would be great. I also wonder, we often have to talk to people who are in business, small business, medium business, maybe one day big, large business. I wonder if it would be worth developing a short slideshow to point out specifically to the business community what advantages a single-payer system would give them.
I think we have that.
Okay. Then I should look better. Thank you.
Right, Ida?
Deb Richter in Vermont has done a lot of work on, especially on speaking to small business and speaking to Rotary clubs because they're mostly small business. And so she's the main person that I turn to for information about that. And I think that we have her slide. If we don't, I'd be happy to connect you.
Okay.
So because the approach is a little, the approach that she uses, which I think is really effective, is a little bit different.
Right.
And instead of going through all the data and so forth, I mean, this is obviously a slideshow for a physician audience, although I've seen it presented to non-physicians many, many times, and people really appreciate it because it's, the first time they're getting like a real explanation of what's going on. So I wouldn't not, say don't use this kind of material because people really appreciate it, but there are some other things you can do with small business, and Deb Richter is the expert on that. So we might even have a webinar with her someday.
We also have this one from Len Rodberg from a few years back. So there are some examples. And Walter Sue has put an enormous amount of thought into the business case as well.
Well, thank you.
I just wanted to add one more thing about the financing, which is that the slide of the financing, it has the new taxes at the bottom, that those new taxes replace what's currently being spent in premiums and out-of-pocket costs, and that 95% of families will pay less. So, so that's also the reason for the part of the tax being a payroll tax, is because otherwise it'd be this huge windfall to employers who currently, many employers fund their workers' coverage, and to have it completely off them would mean, like, we'd have to come up with a different source of funds for what the contribution that employers are currently making. So having a small payroll tax recoups some of that money.
Ida and I were talking about the presentation of the Affordable Care Act in this talk before I did it. And do you think it would be useful to make a basic slide about how the ACA works, that it expands Medicaid significantly, that it subsidizes the purchase of health insurance for people below 400% of federal poverty, and that it makes compulsory the purchase of private health insurance for those above? Do you think that that's how people will get insurance through the Affordable Care Act? Do you think that's useful? Is that necessary, or do people know that stuff now?
I think it would be helpful. I don't want to assume anything.
Could I, this is like Katie from Boston, couldn't I just throw in one thing that I've used on talks, and that is Atul Gawande's articles in the New Yorker, in which he was the one that pointed out the 4-to-1 ratio between costs at McAllen, Texas, and the Mayo Clinic, and the obvious difference in quality of care. And that's a compelling argument to get some uniformity in the system and get rid of.
Ida, I'm trying to think of the exact slides, but we've certainly used slides to that effect, that there's an incredible disequilibrium in where the resources go.
And there's data from Medicare that there's an inverse relationship between outcomes and costs from all the various areas based on Medicare spending.
Mm-hmm.
High spending being correlated with worse outcomes across the country.
I think that there is a huge focus on overuse in our, just our health policy discussion and our discussion of healthcare reform nationally. And I think what we try to point out is that there's a huge problem with underuse as well, and that the underuse is where we're really not serving people, and that one of the things that happens when you give people access to care is that you, the whole population, is that you, physicians' practices shift. They shift from healthy and wealthy relatively now to a sicker and poorer profile. So, so some of that, some of the overuse is driven by the fact that, physicians and hospitals have target incomes and revenues, and they, they don't have sick people to take care of, and they're doing more on healthy people. So I think there's also a lot, so naturally by including a larger segment of society in the health resources that they're actually funding. I mean, most of the uninsured are actually working and paying taxes, and taxes fund the majority of our healthcare system. So they're funding the healthcare system, but they're not getting access to it. So bringing them into accessing it will help with that in and of itself. But also the single-payer system allows you to have data, that kind of data that you can have from Medicare that you couldn't get from any other insurance, provider, insurance company, because it's all proprietary and so forth. So you can have that kind of data for the whole country and see where you need to target interventions to, have use be more appropriate. And of course, also single payer is the most effective at controlling costs. So, being able to negotiate fees in globally budget hospitals and stuff, you can, and do your, control your capital budgets. You can do a lot more like right sizing of the healthcare system. So, like for example, in Chicago, we lost all our hospitals on the south side of town where the greatest needs are, and we've got them all now growing in the affluent suburbs. So because there's no public control over where the capital investments are made. So I think those are, I don't know that any one of those responses really answers the question of variability. Those are some of the possible responses sort of from the single payer perspective to that issue. I don't know if any one of them seems more compelling than another one, but I guess I don't have like a one-sentence soundbite to answer that.
Andy, this is Oscar. To try to answer the question of including the Affordable Care Act, and I tailor my talks depending on the audience, so this obviously is more for a Grand Rounds, which is to our colleagues. But I think it would work for any audience. What I've been trying to do, although I'm a big supporter of President Obama, I'm not a big supporter of the Affordable Care Act. So I do explain, at least briefly, the Affordable Care Act, because there is, even amongst our colleagues, a lot of misinformation. And then what I do is sort of deconstruct it, and in order to compare it to what we propose, to show why what we propose is that much better. So I think in that sense, I like to give some explanation of the Affordable Care Act.
Yeah, that's very good. I think my thought about the Affordable Care Act is that we should be making the point that the Affordable Care Act is not the healthcare system, that it's a specific insurance reform driven by the problems in the system, but ultimately it doesn't impact the system in a way to reform the whole system without taking the ACA directly on. I think that we take the system directly on, and sad to say the Affordable Care Act isn't adequate to make change. And some things are going to get worse under the Affordable Care Act, especially the privatization of everything. Privatizing public programs, hospital conglomeration, for-profit incursion into the direct delivery of care, and pushing more and more people into private insurance schemes that are really inadequate. So, I mean, I think it's tricky. It's a difficult, I think it's a difficult moment because some of our colleagues would like to, like you were saying, you were implying, think that all of the problems in the system can be blamed back to the Affordable Care Act. And maybe some of them are getting actually a little bit better, but many are gotten somewhat worse. But all those problems were there and have been there. So I think it's how would you respond, Oscar?
Well, basically, I mean, I totally agree with you, but I use it sort of as a jumping point or a segue. Yeah, you're right. I mean, because even looking at the slide in front of us now, it's just scratching the surface of the real problems of the system. But again, it's getting the most press. Everyone's talking about it, and so we should take advantage of the attention that it's getting and use it sort of as a jumping point to say, well, okay, we can talk about certain aspects about it, but we actually have a better way of doing this that would work for everyone, and this is why. So it's a jumping point.
Yeah,
this is
quite right. Go ahead. Sorry.
This is Mike Huntington in Corvallis, Oregon.
Hi, Mike.
Hi. 3 questions. One is how best to inveigle ourselves an invitation to a hospital CME program, especially in Corvallis where it's mainly specialists. And that leads to the next question. To take care of any patient, you have to address their fears first. And so when you sit down and talk to the specialist, you have to address his or her fears, which is my income. We need to be able to answer that. And finally, we need to realize that piling on these beautiful facts onto an amygdala that is centered on self-preservation may not make us friends or get us very far. And I think we need to include ways to get to the gut and the amygdala. Can you comment on those 3?
Yeah.
That's great. Well, I think we're glad to try to help land Grand Rounds. That's one of the things that PNHP staff would be glad to try to help figure out with you. With respect to talking to specialists, the specialists that I get along with best, many of them totally misunderstand my personal politics, as turned off as they are. But nevertheless, they are outraged at how silly it is that they would do the same procedure on patient A and patient B and get completely different reimbursements, and also have to command an army of people to fight for those disparate reimbursements. And even those very conservative procedure-driven specialists will say sooner or later it's got to be single payer if you listen to them, because the idea that there should be some basic fairness, and some appropriate compensation, and also the fact that every customer of theirs would become a paying customer, they realize that that might be a more stable way going forward. Mm-hmm. One of the things I'd like to point out to the medical society people, that's the AMA, the New York State MISNY, Medical Society of the State of New York, is that they have done a wonderfully successful job of getting what they want when it comes to bargaining with the government, in terms of lobbying, for example, in terms of staving off the Clinton balance, the SGR cuts. Doctors are very effective when it comes to speaking to the public and the politicians and saying this is what we think we need. The American Medical Association's own position is that when it comes to the insurers, we have no bargaining power whatsoever. So if you really wanted to protect the profession, you would probably do better under a system where the government were making, and the public were making the reimbursements. We know that our patients value us as physicians and so on. So I really think those are interesting discussions to have with physicians, but not difficult ones.
Thank you. Thank you.
Andy, this is Don Collish in New Hampshire. You know, I'm still back on the slide about funding, and I was wondering whether, because that slide is now almost 25 years old, and we did have some comments about breaking down the new taxes. I wonder whether that slide could be updated with Professor Friedman's data.
What do you think, Ida?
The funding for the NHP slide, I guess absolutely we could update it. It actually isn't, even though it's an old slide, as far as the sources of funds, it's actually pretty accurate, but that's a great suggestion. We could definitely do that.
I mean, one of the reasons that I would like to see that updated is that in my neighboring state of Vermont, which is closer to having a single payer than any other state plan, there's been a lot of criticism because of the lack of transparency of funding. And so I think that will be on people's minds. Mm-hmm.
Well, in Vermont, they don't have a funding plan yet for the single payer system. So, I mean, they can't really be transparent about a plan that they don't have. But for HR 676, the plan is, you know, the 6% payroll tax on the people with incomes over $250,000, and the Tobin tax if we can get it, and the 6% payroll tax and so forth. But it's important to remember that when we describe these taxes, we're really just describing the replacement for what is currently spent out of pocket and on premiums, which actually is only, you know, the vast majority of spending on healthcare is already publicly funded, probably 65%, or, you know, maybe approaching 70%. So it's that sort of that iceberg of funding that people are already, you know, our health system we're already financing, but people never hear about it. And that's a little bit what happens when you end up trying to create a financing plan for a state like Vermont, is that that iceberg, then people, all the parts that you never saw before that are just funded in through your taxes, now you see. And so it's easy for the opposition to say, oh, this is a huge tax increase, when actually it's not. It's actually mostly what you're already spending. I don't know if that makes sense, but that's part of what's going on, because the opposition in Vermont is saying, you're going to have to raise, $7.1 billion, I think it is. So you're going to have to raise taxes $7.1 billion. Well, what they're not saying is that they're actually already spending that much in taxes and premiums and out-of-pocket costs. And so the marginal amount they need to raise is actually, nothing. And then in future years it's negative, right, because the single-payer plan saves money.
Yep. Thank you, Ida. I think that does clarify it. And I think that the more that we can highlight that a little bit, and I think Friedman's data probably would do it with a slide, would be terrific.
Yeah, I think one of the other challenges they have in Vermont is, refuting the ACOs, which I don't think they're not on track to be successful with. Medicare gave them a huge amount of money to do, their quote-unquote innovation there. And I just, one comment I was going to make about the slideshows, I think there were a couple slides sort of setting up ACOs and then the ACO logic, but not necessarily refuting it. I don't know if anybody else felt that way. Because how Andy went through the slide about, if you think fee-for-service is the problem and you have to shift to capitation, then you have to do this and then you have to do that. I guess I felt like you explained the whole logic for it, but it didn't really refute it. So I think you're still susceptible to questions like, well, there's all these variations in Medicare, and so what we really need is a big ACO to control everything.
So that people can get rich.
Yeah.
More on refuting ACOs in the longer slide set.
Yes, there's quite a handful of very good ACO slides. Yes.
This is Oscar. Getting back to the question about specialists, I struggle with that. I'm an emergency physician, and I was a little naive, thinking, well, amongst my colleagues, we give away 25, 30% of our care is free. So I would think my colleagues would jump on board the PNHP bandwagon, and surprisingly, it's the opposite. And I really struggle with trying to communicate to them. Our ACEP organization, their official policy is they support a universal health care in America. And I've been struggling at that level to try to get them to add just 2 words to that sentence: single-payer universal health care. So yeah, it's tough, and I think part of it is what we're doing is just giving them information, little bits at a time. You don't, like you said, you don't want to overwhelm them, but and then I tell them, look, this stuff is not me making it up. It's published in peer-reviewed journals by people mostly smarter than I am, but I'm just reporting it to you, and hopefully you'll have some thoughts about it. And but that has been a struggle for me. Like I said, dealing with my own specialty, let alone some of the specialists.
This is Mike Huntington of Corvallis.
Yeah, Mike.
Yeah, Paul Hochfeld is a emergency department doctor also, and the you would think he would be very persuasive at his group also, but every time there's a Medicare regulation that stymies the ER docs, they say, and you want the government to take over this? So can we develop an antidote to that venom?
Yeah.
you know, I think appealing to the better nature of the physicians is my strategy. Incidentally, I tried to write the emergency room case for Singlepayer a few years back when I was invited by the New York ACEP newsletter editor to do that. And I know that Jim Michener has done the same in Michigan. I think who's an emergency room physician. So I think we might think about how to do that. But the ER, the ER understands the social conditions of the community almost better than anybody, and the kind of programs that would keep the patients out of the emergency room who are the bane of our existence in the ER, who really have difficult social problems, would require nothing less than getting our arms around all of the resources in the health system so that there could be adequate home care, adequate social work, social services, and all of the things that would be a true safety net to provide, really good care. Certainly, the nursing homes, for example, the patients that are the most difficult that come from the nursing homes come from, in my experience anyway, private nursing homes that have literally one RN on duty in the whole building. Sort of shocking situations. And in order to have that kind of delivery system reform, which I think is our real goal, it's not just the finances of healthcare, it's really to reform the delivery system. And I think we would have to really have a democratic control over all of the resources. And I think that gets to a little bit of a different discussion, and also a different discussion for maybe a different audience than physicians, which is how liberating it would be for all of us if absolute access to necessary care were available for everyone with no money in the way of personal expenses, if we really shared the costs across the society fairly. And so I think there's a way to take the better nature of physicians to that second discussion about what kind of society do you want to live in and practice medicine in.
Thank you, Andrew.
This is Steve Kemble in Hawaii. There's 2 points I would make to the specialist physician. One is that you're going to have a huge number of people with the growing cost sharing for the patient who are going to be unable to pay their bills. And this is something that's really going to affect their income increasingly if we don't do something that provides a universal system where everyone's upfront costs are covered.
Thanks. If I don't get a chance, thank you, Andy and Ida, for a wonderful presentation. This has been very helpful.
Thank you for the chance to do it. Thank
the
you,
other
Emily, for the inspiration and the hard work.
The other point I was going to make is the difference is in your slide. Between Canada and the U.S., the overhead is much, much lower in Canada.
Yes. Where are we? Coming up to the conclusion because it's 15 past. Is that right?
Yep.
All right.
Thanks, Andy. Thanks, Ida.
Okay, we'll get the slides in the email.
Very good. Thank you.
Thank you.
And
Thanks
the
a lot.
funding.
Thank you so much.
Thanks, Andy.
Oh, no, thank you. I hope it was useful to everyone. Talk to you on the phone.